Thank you all so much. It was a great presentation. I have a question for Dr. Goff. You were referring to the fidelity of the intervention and being careful along the way. There's a new concept now of step wedge. It might not be new, it's new to me, but of the step wedge approach for implementation. How much can we deviate from the original intervention fidelity along each step? I mean, just a discussion. I don't want specific.
So just so maybe everybody knows what a step wedge design is, but it's the idea where you want to eventually give the intervention to everyone, and so you might have a waiting list, and so you might have multiple waiting lists. So you might randomize to intervene in this group and not in this group initially, but then they get brought in later as a intervention group, and therefore you have the pre-post in that group as well as there are a comparison for the initial group, and you could have multiple groups and multiple steps and so forth. So yeah, I suppose you could be tempted, based on what you learn or think you're learning about intervention implementation, to tweak the intervention between steps, and you know, that's a very reasonable thing to do. I think that the challenges that come with that have to do with you know, again, making sure that you don't tweak it to the point where you can't disseminate it ultimately. So hopefully that wouldn't happen. And the other is that at the end of it, you're probably going to want to pool the experience of the intervention group. And if the intervention changes so much that you can't pool it, then that would also be, I think, a bit of a challenge. But otherwise, I think within reason, this idea that Spiro mentioned of flexible uniformity is very reasonable. I don't know if others have comments.
Just to tack on to what David was saying, the flexible uniformity came prior to the implementation of the intervention. One of the challenges we faced was that we had to have evidence that this intervention would work, or we weren't going to be in a position with the policymakers and funders to be able to justify it and expand it and institutionalize it. And if you change things along the way, and you come out with less than the anticipated level of desired outcomes, you don't know what's responsible for that. And for us, it would have been the death knell, because we wouldn't have been able to demonstrate what the evidence-based practice initially suggested we should.
Yeah, I would just underline that I think, you know, it's important before you launch the experimental model that you determine what are the core elements that can't change and what are the sort of more adaptable elements. And I think sometimes you can do that, and then you can be reasonably comfortable about certain things changing. But I would agree that you want to do that before.
Other questions? Comments? Yes. Hi, also on the topic of fidelity, I'm wondering about the balance between fidelity and scale, where, like Dr. Goff had mentioned, a train the trainers who train the trainers model, and just kind of preventing drift.
Yeah, so one of the ways that we envisioned a disseminatable approach to trying to maintain fidelity was to have the community health workers meet as a group. And when they met as a group, that group meeting was facilitated by the diabetes educator at the Diabetes Care Center. And so that provided them the opportunity to get together, talk about how things were going, raise issues that were coming up within their groups, and develop strategies as a group to deal with them. Also, there was, as I mentioned, the enduring materials, where we developed DVDs, videos of the content from the DPP curriculum, so that there would be kind of standard information transmissal. We didn't have to have experts, and I like Spiro's comment about, you know, experts. The community health workers didn't have to be diabetes prevention experts, right? They needed to be really people who lived the life of the community and could relate to people who were sharing that same life and the challenges they're facing around diet and physical activity and lifestyle. and be able to bring people together and be good group facilitators. That was really the key there. So, that's the way we tried to focus on making sure the intervention was going reasonably similarly across the groups, and we thought that was disseminatable.
Any others? I'm wondering if maybe Ross or Julie or are there any other things that you would want to add based on your experience when you've been designing at the design phase that could be points to add, or put you on the spot again?
I think that between what we saw in the introductory piece and these examples, I think our one of the big, what you'll hear over and over is stakeholder involvement early and often. And figuring out how to do that, who the stakeholders are, how you keep them engaged when the research products might be 5 or 6 years out, I think is always tricky. So we've frankly gone through a lot of stakeholders and trying to keep them engaged through the years and keep them over and over. I think some of the best, we've got, one of the things we've looked at in some of our designing for dissemination is among researchers, who are the best disseminators, and by far the strongest predictor is someone who has practice experience. And so if you can find researchers on your team who have worked in practice, done an internship in practice, spent time living in that other world, that might be one of the most important variables to keep in mind in this sort of engagement process.
If I could just add to that, Ross, when I think about models of dissemination implementation, I think that we haven't progressed far enough to have more practice-based researchers who are implementers and disseminators. And I think from the various projects I've been on, it's really clear to me that living in that practice setting and understanding it is very, very critical to success of dissemination efforts. The other comment I was going to make about the planning for dissemination is when I think about it, there's one simple question that I often ask for the stakeholders and delivery system leaders, which is, when we get to the end of the project, are you willing to commit to supporting this dissemination effort? And, it's kind of a simple question, but it's a very important one. And also to be asked at everybody who has influence in making that decision.
I had a question for Arnie Beck. After you did the social network mapping and identified the opinion leaders and patterns of advice seeking, can you elaborate a little bit more about how you used that information in your project?
Sure. The social network mapping confirmed some of the things we knew by being in the practice setting and observing and talking to the folks, but it also identified people we didn't know who had some influence that wasn't sort of immediately obvious. And so what we did then is in the planning and early implementation phase at the clinics, made sure that they were involved and sort of collaborators in that process, and they might not have been thought of as collaborators before. But these are individuals who could make or break something. For example, if you have an MA, one of the social network map I showed had an MA who was particularly influential. We wouldn't have intuitively known that necessarily. But we made sure that in the clinic leadership at that practice that we included her in the decision making and planning for this, and also sort of anticipated what the barriers would be. And I think that ends up often being one of the more salient sort of benefits of the social network map, is identifying what could kill it, by looking at people who have influence and influence in a negative way.
Just a couple of follow-up points, and thank you all. These were wonderful case studies there. Just on this issue of designing for dissemination, which I think I love the different ways that you all come to me. I saw this emergent commonality across that. But to me, this goes back to one of the earlier things we talked about today, that's the difference between D&I science and local QI. And again, you all said it in your own way. For me, maybe David kind of hit it on the head the most, about you ask yourself, can others do this? Can these other 3,000 centers do it? Where if you're doing local QI, in some ways you really don't care about that. You just want to produce your best result for this setting right now, today. But if you ask this broader question about that, and there's one other thing we can send along here that I like. It's one of the most systematic approaches to this that I've seen, that Laura Leviton and colleagues at Robert Wood Johnson have developed what they call an evaluability assessment. And there's some tools and questions, but it's exactly those type of questions that each of you ask along there. But I think that's a useful kind of trick of the trade. And then just to build a little bit more on the partnership, Ross's comments and the nice examples that you had of partnerships, and maybe ask the panel to reflect a bit. To me, I also think that's one of the secrets maybe I would add just a point about its ongoing involvement too. I think a lot of people, those of us that are trained traditionally, we kind of get we need to do this, but it's not enough to just hold an initial planning meeting with the stakeholders, and then you come back and see them 5 years later. But how, and I think if you have any thoughts about how to have that be ongoing partnership. And then the other issue that, again, I guess a question, but reflecting Spiro's point about some of this where it really is art, maybe more than a science, about, in my experience, the different stakeholders, almost all of these are complex multi-level interventions where you have different stakeholders. Those stakeholders have different perspectives, and they likely don't always agree. And to me, that's one of the things we need to work through. That what do you do, and how do you handle that issue?
Well, I noted in our 14-month planning period, we met with the 3 to 5 grantee staff of each of the 36 grantee programs for 2.5 days, 6 times in a year. We continued that. We met on a quarterly basis thereafter for 2.5 days each of the successive years. It was absolutely critical. And one of the things we anticipated, consistent with the notion of peer-to-peer learning, was that in fact by end of year 2, we turned over the planning of the grantee meetings to the grantees, and we became facilitative and supporters of that. And they knew themselves better than anybody what their technical assistance needs were, what were examples of success that they wanted to share. And again, it was the opportunity to bring to the fore 2 things: their creativity, and secondly, their sense of actually controlling the agenda within certain parameters which they had all agreed and been socialized in the first year. So.
And one comment I'd make about the first point, Russ, is that what you're describing is a little bit antithetical to kind of a traditional academic model, because you end up spending a lot of time in the trenches understanding and developing collaborative relationships, which are critical to make anything like what we're talking about work, and which I think are really interesting, but they also take away from grant writing and other sort of traditional academic activities. So it's a tension that I've been aware of for years.
I just want to comment on one of the problems with our project, despite the fact that, well, first of all, it could have been an entirely top-down approach, because the state public health department has the right to recall kids without any involvement on the part of practitioners, or, So we thought that was a mistake, obviously, and we thought it would be more powerful if we did involve them. But it brings up a problem. Our project brings up a problem because the dissemination seems like it would be a slam dunk, right? It was cost effective, it was more effective, but the partners that weren't involved were maybe the payers. And, who's going to pay for this? Because the public health department, they don't have the budget. Practices don't have the budget. Somebody needs to pay for this. So future iterations of our project are trying to involve payers as well in that, mixed with an upfront, as you said, upfront commitment that they will consider supporting this.
Yeah, just a couple of thoughts. One is, as I said, we were advantaged by having a community advisory board already for the Diabetes Care Center that we work with, so we were able to stay in touch with that group through our relationship with the with the center, and in fact, the medical director of the center was one of our members of our investigative team. So that was very close. And then we had the next level of stakeholders, our diabetes educators. We interacted with them regularly, and they interacted with the community health workers. So that there was an ongoing kind of partnership reinforcement. And we did lose a community health worker or two along the way that, for a variety of reasons, which, of course happens with staff turnover and so forth. The other thing in terms of dissemination and testing this idea that, have you made decisions along the way that harm the ability to disseminate? We don't know for sure yet, but right now the group in North Carolina is working with 5 local health departments to see if this program that we did in one diabetes care center can now be done in 5 local health departments at a distance. So we'll see whether we get some sort of fall off in the intervention as it gets further away from us, and whether certain things that we did they're able to do or not able to do.
So I'm just wondering what you guys are seeing in terms of adoption, just the idea of the importance of dissemination and implementation at the federal level. Obviously, it's something that affects a lot of work, and I think that there is maybe a more natural acceptance of this kind of theory in an academic sense. What I see when we have discussions with our federal contractors is that they don't start with the idea that maybe they should get input on what is actually happening and then make plans. It's like they decide that something is important and move forward with it, and the money is already allocated before the evidence is there, that maybe that's the right way to move forward. And I'm just wondering if you've spoken at all to any of the federal agencies and have a sense of whether or not this is even on their radar.
Are you talking about funding agencies?
Yeah.
Oh, yeah.
Specifically CMS, but I think it's true of a lot of, I think there's a big difference between NIH's approach and CMS's approach.
Yeah, that's a good point. And we're involved in one of the CMMI projects, and actually they do seem to be very supportive of implementation dissemination efforts. It's around 9 sites across the country, and by definition, I think they have to pay attention to that. I also think that we're seeing more of that kind of language and method and just framework come into the RFAs. But that said, last time I checked, maybe it's different now, late stage translation is like 5% of the NIH budget. So I think there's still quite a ways to go. And correct me if I'm wrong on that, if there's newer data. But so it's still a matter of walking the talk, I think, in some ways.
I think your question really raises an interesting issue for me. I've always, in the 3.5 decades of my career, seen myself as a scientist, but also as a translator and broker for Native communities in terms of bridges to resources. And so I'm before Congress 3 to 4 times a year to the various committees that are relevant to the health initiatives that I'm involved with Native communities. So I see it as bookending the process. And by educating staff and congressional representatives, current circumstances suggesting otherwise is that as a possibility, you get the pressure down from the funders and policymakers, and then with the advocacy groups from your constituents moving up, it tends to make the educational process quicker and more effective with the agencies in between who fund these kinds of things, in my experience. But you know what? Did you ever have a graduate course in advocacy or translation around research findings and its application in the real world and these kinds of things? And I think that's a really missing part of our training and preparation as scientists if we're going to move into D&I.
I think Sparrow makes a good point about the advocacy groups, too. There's this kind of bottom-up pressure on some really key sort of public health issues that manifest in RFAs that if they align with your work, it's really more likely that you're able to use D&I concepts in those kinds of things.
Yeah, and I would say D&I is more on the radar now at NIH than it was 10 years ago for sure. Witness the study section that Ross is now chair of, and I chaired for a couple of years before him. It's also on the radar at CDC, although they think of it more in terms of community-based rather than health system-based. And ARC, of course, has this concept, as does PCORI. So I think there's more and more adoption of this approach. The other thing I would say about advocacy training is that I think the best advocacy training I've had in my professional career was through the American Heart Association, shameless plug. So if you want to develop your ability to be an advocate, you could do a whole lot worse than deciding you want to volunteer for a really top-notch organization like the American Heart Association and get some advocacy training and get involved at the state and federal level to advocate for something important like cardiovascular health. Shameless plug.
We have time for one more question before lunch.
This is a little bit of a follow-up on the prior question, but what struck me about these projects is that they are long-term investments in a particular intervention with particular population or set of stakeholders. And following up on the kind of funding issues, I have had funding through ARC. You're talking about a 3 or 4 year funding cycle, not a huge amount of money. And how did you clearly these types of things and like CMS, they want things that are, the shovel-ready idea. We're just going to put it out there. There's not really a lot of interest in planning phases, from what I see, to fit a dissemination project at multiple sites into a 3-year window on a limited budget seems to me to be, counter to the whole way that this works. It doesn't fit into the classic structures.
Yeah, I'd like to comment quickly on that because the CMMI project I'm involved in is it's one of those 3-year projects, and because across all 9 sites enrollment has been slow. This is for patients with poorly controlled diabetes or heart disease and depression and care management, behavioral health interventions. I'm having to actually go to our stakeholders and leaders in our organization to start to put together the elements of a business case. That's how everybody likes it in our system, for sustainability of this model and whose budget it fits into. And so I'm having to do that like a year before I even thought. But I think you're raising a really important point that well before the end of these relatively shorter term projects, we need to be talking to other stakeholders around funding for sustaining programs and be able to do whatever we can to show evidence for the business case for it.
Yeah, I would just add to that like everything else in life, you need to beg, borrow, and steal everybody else's infrastructure. So you should try to find out what practice-based research networks are in your area, including public health practice-based research networks. There's a public health practice-based research network here. There's a practice-based research network here. There's multiple of them around the country. And so you need to, if you're just getting started, you need to find somebody who will take you on and let you beg, borrow, and steal their infrastructure, because then it makes it more practical to be able to do this. If you're starting de novo with no track record, no experience, no infrastructure, you can't expect to be able to do the sort of project that you're talking about in a 3-year period. But if you're working with someone who's kind of been there, done that, and has some infrastructure you can borrow, you may be able to get that done.
Okay. Well, thank you very much. This has been